and malaria, and there may be some other febrile illnesses as per the seasons. Accordingly to nowadays, the most common febrile illnesses which are presenting, these typhoid and malaria are all the time endemic in our society. I hope you understand the terminology endemic. Endemic diseases are those which are present all the time in our society in a good number. So these communicable diseases in our developing societies, they are most of the time present, nearly all of the time present in a good number and daily presence to you in your clinics and OPDs along with these symptoms. So how can we prevent in community medicine and public health? We most of the time try to discuss or try to target the strategies through which we can prevent the occurrence of these diseases before their occurrence. Okay? Before the incidence, before the prevalence, before they present to us. Or we try to prevent, we try to protect our population before they get infected through these diseases. So we will try to see that how can we prevent these typhoid and malaria and other febrile diseases. Now you see, in every disease, if you will study in depth the dynamics of that diseases, then you may find out that this disease, any disease, has some weak points, some weak corners. And we have to sort out, we have to find out that weak point, and we have to attack at that weak point, and then attacking that weak point, we can break the chain of transmission of infection. Chain of transmission of infection means that chain through which this disease involves other person from one person to second and third. If we try to break this transmission, break this chain, and then we may be able to prevent, and we may be able to protect other people from getting infection through one person who is already infected. But how can we break this chain of transmission of infection? For that, we have to have a very, very thorough knowledge, in-depth knowledge of that disease, the causation of that disease, the transmission of that disease, the sources of the disease organism or disease causation. So a public health physician or consultant has to have very sound knowledge, more knowledge than a physician, than a clinician, because he has to stop the things before they originate. So we have to identify these weak points and then break the weakest link in the chain of transmission. Now see, how can we do that? This requires a sound epidemiological knowledge of the disease, and this sound epidemiological knowledge, what do we mean by that? We have to know, we have to have the knowledge of magnitude, the knowledge of distribution, the knowledge of causation, whether there is a single caused disease or it has multifactorial causation. Where are the sources of infection, and what are the dynamics of transmission of that infection? So if you are looking at this slide, then you must memorize the first lecture of epidemiology that you probably have had in your last classes. That what is the definition of epidemiology? So if we see sometime in previous lectures, I told that if you want to remember the definition of epidemiology, you have to remember 3 Ds. 3 Ds, 1 D for the dynamics, the another D for distribution, and the next D for determinants. So if you want to define the epidemiology, you may say that epidemiology is the study of determinants, dynamics, and distribution of health-related events. I will go in the details of this definition of epidemiology sometime else. But at the time, you remember 3 Ds. We want to know, we want to study, we want to have know-how of number 1, the determinants. number 2, the dynamics, and number 3, the distribution of these diseases. So, what is the determinant? Determinant is the cause of disease. And determinants may again be divided into the primary determinants and the secondary determinants. So primary determinants are the root and major cause or the principal cause of the disease. For example, in the case of, say, typhoid, the primary determinant will be the Salmonella typhi. Or if we take both the typhoid and the paratyphoid, and we call them enteric fever. Enteric fever means typhoid and paratyphoid both. So here the primary cause is the Salmonella typhi or Salmonella paratyphi. These are the bacteria which are causing this typhoid infection, but this is the primary determinant. Then what are the secondary determinants? Secondary determinants are those causes, those factors which predispose or which supports the occurrence of the disease. For example, in the case of the typhoid, you see that a secondary determinant may be the water, the contaminated water, through which these Salmonella typhi are being transported from the feces or the urine of one infected person, getting discharged from there, contaminating water, and then the pupils who are drinking that water or eating that food which is being contaminated with that organism. So this water source or the food source, these are the secondary determinants. Okay, in the case of say tuberculosis, the major or the primary determinants is the Mycobacterium tuberculosis, which is the organism which is causing that disease. But the secondary determinant may be the host factor. Okay? Less immunity of the host, lack of vaccination in the host. These are factors, these are determinants are predisposing or supporting the occurrence of diseases. So these are the determinants. Then distribution, which population is being infected, whether they are all the population, the elder ones, or the younger ones, or the children. For example, in the case of the measles, the population is the pediatric population usually. For example, in the case of tuberculosis, it may be any age of the population, usually the young adults. For example, if you see the COVID-19, any person can be infected, but in this distribution, you see morbidity, the disease may be present in any person, but the fatalities, if you will go towards the fatality, the lethality, the deaths, aged persons or the persons with the comorbidities, it is more lethal for them. So this is what the distribution. Then determinants, distribution, and dynamics. Dynamics means the magnitude. Okay, how much is the volume, how much is the tau of the disease. Okay, so how much number of the cases of typhoid are present right now. That means what is the prevalence of typhoid right now. How much new cases, how many new cases every year of typhoid are being reported in our society. That means what I am discussing about is the incidence. This is what the incidence of the disease, new cases. So in all these things, magnitude, distribution, multifactorial causation, sources of infection, dynamics of transmission, you see, we are discussing epidemiology of the disease. We are discussing, in short, in brief, 3 Ds. We are discussing the determinants, distribution, and dynamics, and we have to have. So if someone, for any disease, not for this typhoid only, for the malaria only, or for other febrile illnesses, for any disease, if anyone has the detailed and in-depth knowledge of the epidemiology of that disease, so he may be able to control the disease. He may be able to target the weakest link amongst the chain of transmission and can prevent that. So what do we mean by the prevention? Okay, what do we want through prevention, and what are the strategies that are being involved in prevention? Through prevention, we want to reduce the new cases to be infected. That means we want to reduce this incidence of the disease. Okay, so if the new cases would not be enrolled, would not be there, then the total number of the cases will be decreased, means the prevalence of the disease may be decreased. So you know better and this most likely have been discussed in the previous classes of the community medicine or public health. What is incidence and what is prevalence? Incidence means the total number of the new cases amongst the total population during a specified time period. For example, if the total population is 100, okay, and new cases that are being reported in the last year of any disease, for example, say typhoid, they are 10. So what will be the incidence? Incidence will be 10 divided by 100, or the formula of the incidence will be total number of the new cases. This will be during a specified time period. Okay, if we are discussing within a year, so in 2020, say. So total number of new cases of typhoid in 2020, this is the numerator, total number of new cases. Then what is the denominator? Total population. Total population, we suppose that it is 100. So 10 divided by 100, and then we take a constant, 100 or 1000 or 10,000 or 1 lakh, maybe. So for example, here I am taking a constant as 100. So 10 divided by 100 multiplied by 100 means 10%. So the new new number of cases are the 10% of the total population. This is what the incidence is. And then what is the prevalence? Prevalence are the total number of the cases that are present in the society all the time, every time, whether they are new or whether they are old. For example, I want to calculate the prevalence of typhoid in my class right now. So if 100 students are there, so I will just ask, my denominator will be 100, total population. What will be the numerator? Total number of the typhoid cases or total number of malaria cases, which I am calculating right now at the time. So I will head count how many people are having malaria right now. So suppose they are again 10. So this will be 10 total number of the cases present right now at the time. This is called the point prevalence, divided by total population multiplied by constant. So if the constant is 100, this is again 10%. So this is what the incidence and prevalence is. So incidence are the new number of cases during the time duration, and prevalence is the total number of the cases during that time duration, and time duration you may take. So by saying that we want to control the disease, means we want to prevent the new number of the cases. We want to reduce incidence. We want to reduce the total number of cases. That means we want to reduce the prevalence of the disease. And plus, how much reduction in the incidence or the prevalence we require. That depends on disease to disease. Our target will be different. We want no case of polio in our country. So we want 0 incidence and 0 prevalence. This is the target for polio, as all the world except Pakistan and Afghanistan has eradicated polio. This is called eradication. Eradication means 0 number of cases, number 1. And there are, remember, there are 2 terminologies, eradication and elimination. Okay, elimination is the ending, finishing any one type of disease. Okay, any one type of disease. When I say, for example, tuberculosis occurs in the human being and tuberculosis occurs in the animals as well. So if I am ending, okay, finishing the tuberculosis in the human beings, but TB in the cows and other animals still persists there, this will be called elimination. Okay, and number 1, disease may occur in any other form, any other type, in any other species, and the disease organism will be present there. But eradication, this is what elimination. Eradication is ending all the types of diseases plus ending the organism of disease as well. There should be no any organism. So if we join 2 eliminations, okay, number 1, all type of diseases, number 2, the organism or the cause of the disease as well. These 2 elimination in joint, they make eradication. For example, there is the smallpox has been eradicated from the world. Means smallpox does not exist in any form in this globe. Okay, neither the organism of smallpox is there. okay, except in a very few laboratories where it has been preserved for some emergency. Okay, so this is what the eradication. So when I write here as much as possible, I mean, okay, according to the dynamics, according to the pathophysiologies of different diseases, our target may be different. Sometimes our target may be to eradicate, sometimes our target may be to eliminate, and sometimes our target may be to control. For example, our target for polio at the time is to eradicate the polio. For measles at the time, our target is to eliminate. Okay. For malaria, our target is to control. So for different diseases, we set up the different targets, and these targets may even change. For example, for malaria today, we are having the target to control the incidence and prevalence of malaria at the time. Maybe in future, we should try to eliminate the disease and then eradicate the disease. Okay, and then we also want to reduce the consequences of these diseases. Consequences means the deaths because of these diseases. Consequences may mean the disabilities because of these diseases. For example, the consequence of a diabetes is the foot amputation. Okay, the diabetic retinopathy and the blindness. So we want to reduce these consequences as well. This is what our targets, what we are trying in controlling. What do we mean by control? Then how can we do that? The measures. And the measures, we require the support along with the medical and the doctor community, and the strategies we want to support from the community. And the community is the direct effective of these diseases. So we want cooperation from there as well. So at the time you see by yourself that we are trying to get the cooperation, participation from the community for polio vaccination. But due to one reason or another, there are some pockets of the populations who are resistant to get immunized, and they are doing different things. So this is what the counseling and education and the health education, repeated social mobilization through which we get the community participation. Then you see the intersectoral coordination, the coordination from different sectors, and we are having sufficient coordination, even that polio program. If you are seeing in the COVID control strategies, you are saying that all the all the sectors of the society, they are coordinating with each other, and they are cooperating with the health authorities and the people who are doing all these things. The cooperation of all the sectors are along with them. And how this became possible? This became possible through this political support. When political support comes along with the health authorities or along with the authorities who are trying to get some task, then every sector comes coordinated in each other. So these are the essential things that we should have a joint effort. Okay. As far as questions came, that what are our target for COVID? Our target for COVID at the time is only to reduce the incidence. Okay, to reduce the incidence, and when we will reduce the new number of the cases, the prevalence will reduce accordingly and in parallel. So, and this is only possible through the health education or the preventive measures, through having the social distancing, through wearing the masks and washing the hands. These are the only studies that are available at the time for not to get infected with this COVID virus. Now the vaccines has come and they are being started, but the vaccines to show their influence or show their effectiveness and give the result will take some time. When near about Say the people are saying that 70 to 80% of the population, if will get vaccinated, then herd immunity will be there. But the studies and the literature, the epidemiological literature, if you will study the book of epidemiology by Mosner and Ban, or the WHO publications of epidemiology, इसी नाम से आती है ये, ठीक है? And then different epidemiological park आप ले लें, तो you will see herd immunity जो है वो that not comes on 70 or 80% immunization, ठीक है? If you replace the word immunization, resistant हो जाए population, ठीक है, 90 to 95%, तब remaining 5 to 10% of the population enjoys herd immunity, because without getting infection and without getting immunized. Okay, so if in any population 90% of the population is resistant किसी भी तरह हो सकती है, okay, they may be resistant either कि उनको infection हो गया. For example, I was being infected by COVID say on July 2020. So most likely I did my antibodies and they were positive. So I was having antibodies. अब ये बात है in August 2020 की, उस वक्त antibody positive थे. Now what are the level of, whether they are present right now in my blood or not, or if they are present, what is the level of those antibodies? These are the two important questions that will demarcate, that will tell whether I am resistant, whether I am safe or not. So if any population is being resistant through getting natural infection or being resistant by getting immunization, if 90% of the population is get immunized and resistant, then remaining 10% of the population is set to enjoy the herd immunity. Okay. So at the time, target for the COVID is just to reduce the incidence and the prevalence, okay, and as a result, the consequences of the disease. And what is the consequence of disease? Consequences of the disease, number one is the death. Number two, maybe the disabilities. There are various things which are coming along, the depression, which goes along with the patient for many months, and many weaknesses and many other things. Okay, so we have to include the community participation, political support, intersectoral coordinations, and these are the measures, these are the strategies to control any disease. And how we can do that? We have to, if you remember one thing, what are the different theories of disease occurrence? हमने कभी पिछले lectures में देखा होगा the theories of disease occurrence. उसमें एक बहुत जो है, there was a very popular disease model, which were the epidemiological triangle. Okay, and epidemiological triangle tells us different models were there. The epidemiological triangle, the web of causation, the wheel model of disease occurrence. एक मॉडल था जिसको हम कहते थे कि that was epidemiological triangle. Epidemiological triangle क्या था? You just imagine a triangle in your minds, or draw a triangle on your pads. At the one corner of the triangle is the agent, on the other corner is the host, and the third corner is the environment. So this relationship in between the agent, host, and environment, this is what how the disease occurs. Okay, disease to occur needs an agent to be there, which is causing the disease. This agent not necessarily may be a bacteria or a virus. This agent may be anything. For example, the iodine deficiency in the nutritional deficiency diseases, iodine deficiency, iron deficiency, they may be considered as a primary determinant, as an agent. Then you should need a host who is susceptible to get that disease, and then you need a favorable environment for that agent to infect that host. Okay, if the environment is not favorable, then the disease occurrence will be, there will be no disease occurrence or less disease occurrence. For example, you see that in winters, the respiratory diseases, they are coming in frequent to your OPDs because of this favorable environment there. So in the rainy seasons or in the summers, the gastrointestinal diseases, gastroenteritis, loose motion, vomiting, these sort of the diseases, they are more being reported because of these environmental conditions. So agent, host, environment. Keep that triangle in your mind. At one corner is agent, at another is host, and at the third corner is environment. This transparency tells us the same thing, that you have to consider these corners. The reservoir or source of the infection you may consider is in the triangle as an agent. Then the route of transmission, this is what the environment. Route of transmission may be the airborne transmission. Route of transmission may be the waterborne transmission, contaminated water, which we all the time are getting in our tap waters. And if we are using these tap waters without boiling them or without sterilizing them or filtering them, we may get the disease, any disease. Okay, and then we should have a host who should be susceptible, that is at-risk population. So we have to consider all these three things. This is what being represented here, and in these three circles, you may draw it similarly as a triangle. Source or reservoir of the infection agent, where the agent is present, who is producing or supplying or reservoir or storing the agent of the disease, who is the source of that disease. Then how this agent is being transferred, what is the mode of transmission, and where is the susceptible host. Okay, now in this transparency, if you see I am trying to control any disease, okay, then what I do, I eliminate, I end up all the sources of transmission. So for one time, you just imagine that there is no any case of hepatitis B carrier of hepatitis B there in the world. So hepatitis B is being transmitted, you know, through the blood routes of transmission or through the sexual diseases route of the transmission. So if there would be no any carrier of the hepatitis B in the world, then there will be no disease. But if the sources are there, the reservoir are there, but they cannot be transferred, the mode of transmission is like that, that we screen all the bloods very thoroughly, very nicely, if they are being transfused from one person to another. Okay, our social mobilization and health education for the STDs is good, and then we are using the disposable needles in the here dressed shops that we are using the disposable blades, etc., etc. So the transmission will not be there, okay? And see, the hepatitis B is not being transmitted through the food route or the orophycal route or the waterborne. It is not a waterborne disease, it is not an airborne disease. So only transmission is through these two routes which I told you. So if we control this transmission, break the chain of the transmission here at transporting level, then there will be no disease or very less number of the disease. Then another strategy may be that I immunize all the population by hepatitis B vaccine, which is available to us if we get 3 doses of hepatitis B vaccine at the interval of dose 1, say for example today, day 1, then 1 month after the dose 2, and then 3 months after the dose 3. There is another regime that day 1, 1 month after, and then 1 month after as well, and then a booster after 2 years. So if I immunize all the population in the Pakistan by hepatitis B vaccination, even if these transmissions occurs there, even if the sources or the reservoirs or the carrier are present there, but the population is being immunized. So we may hit any area of this chain of the transmission, or we may hit at the multiple points. We may work at all the time with the sources, with the transmission, and with the susceptibles as well. We may hit all the time. For example, in the malaria control, say, for example, what is the source? Source is the person who has had malaria and he is having gametocyte in his blood. That's the human being. Malaria is also present in many other species like the monkeys, etc. So that may be the source as well. What is the transmission mode? Transmission mode is a vector-borne disease. So mosquito bites the person who is having malaria. For example, I had malaria few weeks ago, suppose few weeks ago, and now I am well. I have been treated, but the gametocytes are there in my blood. If one mosquito bites me, he may suck my blood and he may suck gametocyte. That gametocyte will go through the sporogony. In the sporogony is one phase of the life cycle of malarial parasite, which occurs in mosquitoes, say, it goes in the life cycle in the mosquito, and then it develops into the sporozoites, and that mosquito again bites any one person who is not having malaria, so he will get malaria. So we may hit here, for example, we may reduce the population of the mosquito, so it is not being transmitted, or if possible, which is not possible at the time, we may immunize all the population with malaria vaccine. But the problem is that up till now, no malaria vaccine is there available for immunization, and there are many technical reasons for these malaria vaccines why it is not being present, because the malaria occurs because of many species. Plasmodium falciparum is there, Plasmodium vivax is there, Plasmodium ovale is there, Plasmodium malariae is there. These are the 4 common types of the Plasmodium which causes the malarial parasites, which causes malaria. Okay, most common amongst these is the falciparum and vivax, and most dangerous amongst these is the falciparum. Okay, when we generate a vaccine for Plasmodium, one species is being covered very well, but the other species is not being covered by that vaccine, and these are the reasons that still, but the work is going on. Hopefully in the near future there will be a vaccine for malaria, but at the time we can work on these strategy that mode of transmission may be break, sources may be controlled, and the personal protection may be here through the screening, through using the repellents, through the nets, etc., etc. So these are the 3 different aspects, different strategies that we can work. Now see, how can we control the reservoirs? Logically, the most desirable control measure will be to eliminate the reservoir or source. If possible, it comprises following. As early as possible, we should diagnose the infected person, we should diagnose the patient, we will notify that patient to the higher authorities, and then we should do the epidemiological investigation. ये diagnosis तो समझ में आ गया होगा, ये notification क्या होता है? Notification is a thing which comes under HMIS. What is this HMIS? These are the statistical statistical reporting of the diseases. Health Management Information System, HMIS. So every BHU, basic health unit, every treatment unit, every RHC, rural health center, every hospital who is providing the treatment, who is diagnosing, he should report to the higher authorities at the DHO, district headquarters, district health officer, and upper levels. These number of the diseases came in this month to me. So the higher authorities should know that what is going on in this society, which disease is being more prevalent at the time in the society. This is what we call notification. And you will study, if you will study a book apne park mein, ya jo Elias and Al-Sarin, Elias et al. If you will see, study the chapter of surveillance, okay, there you will get this notification. And there is a special chapter, Health Management Information System. Then epidemiological investigation. What is this epidemiological investigation? Epidemiological investigation ye hoti hai, when you see a case, okay, that is not the only case that is present in the society. That is the case that has been presented to you. There may be multiple number of the cases, large number of cases that are being present in the society. Okay, so this is the index case that has been presented to you. There are the primary cases which are being present in the society. So you do the epidemiological investigation. Very good example. Very good example of say this epidemiological investigation is that in the form of the COVID. So in COVID, when one person comes, you screen all the persons in his family, that who are other persons that are being involved. Then you isolate that patient, so it may not propagate the disease, spread the disease. Treat the epidemiology, early diagnosis and prompt treatment, best treatment. These are the best options. And then quarantine. What is the difference between quarantine and isolation? Isolation is for the diagnosed cases. Quarantine is for the cases who are suspicious at the time, and they are not being isolated. They are not being diagnosed. So you give the test, quarantine them at one corner. When the test comes, whether if test is positive, you isolate them. If the test is negative, they may go along in their society. Then the second corner, interruption of transmission. You see, we did the sources of reservoir, and then we are not doing mode of transmission. The major aspect is the of controlling the communicable diseases relates to the breaking the chain of transmission. This means preventing the infective agent from a patient or a carrier to enter the body of susceptible person through sterilization of the water, through using of the mask and the filters, so the airborne diseases cannot enter. And water is a medium of transmission, you say, for the typhoid, dysentery, cholera, and gastroenteritis. So water treatment will eliminate these diseases. This is the transporting channel. For example, in the malaria, vector-based transmission. So if we control the vectors, means the mosquitoes, there are less number of mosquitoes, or we do something like that. These mosquitoes, if even they are present, they cannot bite us using the nets. So this is what we mean by the interruption of transmission. And then we discussed how the susceptible host can be converted into the resistant host. They are no more susceptible for the disease. So if the organism comes to them, it cannot infect them. This may be due through active immunization. So you have a whole immunization program in which you are immunizing against the 11 diseases. Then there are passive immunization in which the antibodies are being injected, and combined active and the passive immunization. There are chemoprophylaxis which are present, for example, for the malaria. If you are taking 3 tablets of the Fansidar is having artemether and lumefantrine weekly. So if the malaria organism comes within your body, it will not infect you. And there are other non-specific measures, for example, the screening of the houses for mosquito and the flies, improving quality of the life, better immunity, better water supply, pure water supply, better sanitation, and better nutrition. So all these are the non-specific measures. So we are hitting the disease at 3 corners: at the reservoir level, agent level, at the transmission level, and at the host level. Major obstacle to disease control is the human behavior, and the human behavior cannot be changed through any technology. Okay, human behavior can be changed only through health education. Okay, so if you want to get the public cooperation, your only tool is the health education. Educating the people, social mobilizing is the main thing. Changing the lifestyle of the people. So health education is the most important thing among all these things. Okay, and such changes could in themselves be powerful method of the disease control. Okay, so now see, all these background knowledge you now implement it towards your target disease, the typhoid and the malaria. So typhoid kya hai? Is a systemic infection caused by the Salmonella typhi or paratyphi A and B. Clinically, they present with the fever for more than 2, 3, or 4 weeks, and this fever is most of the time is the continuous type of the fever. Continuous type of when you will study, आपको देखिएगा Hutchinson's clinical method, okay? या आप एक मोहम्मद अली क्लिनिकल मेथड और क्लिनिकल मेथड की जो हैं उनमें आप फीवर की क्लासिफिकेशन निकालिएगा, देन यू विल फाइंड दैट कि जनाब रेमिटेंट फीवर क्या होता है, व्हाट इज द इंटरमिटेंट फीवर, व्हाट इज द कंटिन्यूअस फीवर. कंटिन्यूअस फीवर ये होता है व्हेन यू आर हैविंग फीवर कंटिन्यूअसली, इट नेवर टचेस द नॉर्मल लेवल, एंड द वेरिएशन इन द फीवर इज नॉट मोर देन 1 डिग्री सेंटीग्रेड और लेस, इट इज इवन. रेमिटेंट फीवर में वो जो है वो कभी कभी नॉर्मल को भी टच करता है. इंटरमिटेंट फीवर में किसी दिन बुखार होता है, फीवर होता है, और किसी दिन नहीं होता. फॉर एग्जांपल इन द केसेस ऑफ द मलेरिया यू हैव इंटरमिटेंट फीवर, एक दिन बुखार है एंड द अदर डे अल्टरनेट डेज के अंदर यू आर हैविंग द फीवर. सो इन टाइफॉइड देयर इज इन कंटिन्यूअस फीवर एंड रिलेटिव ब्रेडिकार्डिया. रिलेटिव ब्रेडिकार्डिया होता है, लोग ब्रेडिकार्डिया ढूंढते हैं कि जनाब हार्ट रेट शुड बी 60 और 62 और 65. इट इज नॉट लाइक दैट. नॉर्मली क्या होता है कि 1 डिग्री सेंटीग्रेड जब टेम्परेचर इंक्रीज होता है तो हार्ट रेट 3 और 4 और 5 पल्सेस पर मिनट जो है दैट इंक्रीजेस. सो अगर किसी के 98.6 डिग्री फ़ारेनहाइट के ऊपर जो है वो हार्ट रेट 72 पर मिनट है, और यही टेम्परेचर जो 100 पे जाता है तो इट शुड बी लाइक 82 और 83। लेकिन टाइफाइड के फीवर में पल्स रेट इतना इंक्रीज नहीं होता, इंक्रीज होता है लेकिन कम होता है। सो टाइफाइड में अगर जो है वो 100 डिग्री फ़ारेनहाइट के ऊपर पेशेंट आ रहा है तो उसका हार्ट रेट में भी 78 और 79, तो यू सपोज कि यार 100 पे तो ज़्यादा होना चाहिए था लेकिन कम है, एंड देन यू देयर इज अ क्लिक इन योर माइंड कि इट मे बी अ टाइफाइड फीवर। दिस इज द रिलेटिव ब्रेडिकार्डिया, and the lymphoid tissue and the reticular endothelial system are being involved, being the gallbladder being the main reservoir of the organism, and that is why कि अगर बार बार किसी को रिलैप्सेस ऑफ टाइफाइड हो रहे हैं तो फिर इसकी कोलिसिस्टेक्टोमी कर देते हैं। वी नो के ट्रीटमेंट के बावजूद जो है the salmonella typhi is being reserved, is being stored in gallbladder and वो relapse कर रहा है बार बार। So enteric fever, as I told you, both typhoid and paratyphoid are combined, they are called being enteric fever. It may occur sporadically, epidemically, endemically, and found only in human. No, you know, sporadic क्या होता है कि जो disease कहीं कहीं हो, rare हो, occasional हो, one slot here and one slot anywhere else. This is what the sporadic is. Endemic, when the disease is present in the society in a good number, but epidemic, when the number of the disease increases, number of the disease persons increases more than usual. This is what the epidemic is. At the time we are facing the epidemic of COVID, everybody know. Typhoid roughly involves 21.6 million people each year according to the WHO estimates. 21.6 million means 2 करोड़ 16 लाख लोग हर साल जो है वो टाइफाइड से इन्फेक्टेड होते हैं, और उनमें से नियर अबाउट 1 to 6% जो है उनकी डेथ हो जाती है। यानी डेथ टोल एवरी ईयर इन दी ग्लोब इज नियर अबाउट 2,16,000 से लेकर 6 लाख तक की डेथ्स जो हैं दे आर ओनली एवरी ईयर इन दी ग्लोब। सो यू सी कि आप इतना ज़्यादा जो है वो अभी इस पैंडेमिक का शोर है। देयर आर अदर डिजीजेस विच आर कॉजिंग सिलो डेथ्स एंड कंटिन्यूअस इन्फेक्शंस, सो वी हैव टू वर्क ओवर देम। It doesn't mean we do not work on this. We have to think about that as well. Okay. More disastrous thing is that among these deaths, these near about 2.16 lakh deaths, 62% of these are in the Asia and 35% are in Africa. So अगर आप इन दोनों को मिला लें 62 and 35, that comes to near about 97% of the deaths जो है वो हमारे मुल्कों में ही हो रही हैं. They are in Asia and Africa, and the advanced countries and the European and American countries are not being affected or infected through this problem. And the only reason is they have broken the chain of the transmission. Their water supply is safe and their health habits are better. They are not immunized. उनके अंदर वो 100% इम्यूनाइजेशन या 90% इम्यूनाइजेशन नहीं है. ठीक है, रिजर्वायर्स कंट्रोल होते हैं. जो इन्फेक्टेड पर्सन डायग्नोस हुआ उसको पूरा ट्रीट करते हैं, कैरियर बना के नहीं छोड़ देते, आधा ट्रीट करके नहीं छोड़ते. 6 वीक्स तक उसका एंटीबायोटिक ट्रीटमेंट ले जाते हैं ताकि उसकी जो रिजर्वायर गॉल ब्लैडर में वो भी खत्म हो जाए. सो देयर शुड बी नो कैरियर, नो रिजर्वायर, एंड ट्रांसपोर्टिंग चैनल्स जो है हैव बीन ब्रोकन. सो वी आर द पॉपुलेशंस हु आर बीइंग अफेक्टेड. Sources of infection, you know, they are the primary sources, which are the feces and urine of the carriers. Feces are the more frequent, and then there are the secondary, which are the channels which transmit the food, fingers, and the flies. Water, food, fingers, and flies. So these are the things. Through the feces, it is in the hands, and due to poor hygienic habits, they are being transmitted into the food items and then goes in, and the water being contaminated there. Okay, how do we control the typhoid? Now see, ये मैरी मेलन जो है, ये जो ग्लासेस पहनी हुई ये खातून है, ये इन्होंने जो है वो क्वारंटाइन कर दी गई थी. ठीक है, दिस इज अ बैक्टीरियोलॉजिस्ट ईमा शर्मा. Okay, this Mary Mellon was a carrier, was a patient of the typhoid, being treated but not treated very well, and she became a carrier, and she was excreting typhoid, Salmonella typhi, in her feces, and through poor hygienic habits, she was having it in her hands. And what she did, she was a cook in a restaurant, and she infected near about 1,300 pupils during her lifetime. When she was being diagnosed, she was being then quarantined. She was taken away from this profession of cooking, and she remained quarantined for near about 26 years. And at the end, she died because of pneumonia. So this is how one carrier can infect how many people through these things. So if you want to control typhoid, the same strategies that we should control the reservoir, we should control the transporting channel, which are the water most of the time, and the food most of the time. So better sanitation, and as the typhoid vaccine is available now, we can immunize against typhoid. So the weakest link in the chain of transmission of typhoid is the sanitation. If we control our sanitation, and our feces and urine should not cross the sanitation pipelines and should not enter the water supply pipelines, there should be less number of the cases. This is the main reason that we are having more number of the cases, more number of diseases, incidences. Usual method of control of reservoir is again the isolation, identification, isolation, treatment, and disinfection. So in the cases, we should early diagnose, we should notify them to the higher authorities, we should isolate them, treat them properly, disinfectant their stool and the urine, and the stool and urine are the sole source of infection, and they should be disinfected with 5% cresol, and then follow them up through the stool cultures and the urine cultures, that whether they are excreting Salmonella typhi in their stools or not. Then we should treat the carriers. If the carriers could reach the Najwa, that is not that difficult. So number one, we should identify them after the treatment, after the fever has subsided, then the patient is all right. We should do the stool culture 1 week or 2 weeks after and see that whether they are excreting Salmonella typhi. If yes, that means they are carrier. We had identified them. Then we may treat them with antibodies for at least 6 weeks. So after 6 weeks, they should not no more. There should be no more carrier. After 6 weeks of the course of antibiotics, we will again do the culture of the stools and the urine. And even if the organism present, then we should have to go for cholecystectomy. Okay? Then surveillance is the data collection for action. We should try to find out the carriers in our society and treat them. And then health education is the center of all the strategies for any disease. Secondly, after doing all this about the reservoir and the carriers, we should control the transmission channels, which is the drinking water supply and the food hygiene. So, Mary Melon ki tarah nahi karna hai. Okay? So this is the transmitting channel, and then susceptible host को resistant बनाने के लिए we can do immunization. However, immunization may not give the 100% protection, but it gives 70 to 95% protection. There are two types of the vaccines which are present at the time for immunization against typhoid. They are the polysaccharide vaccine, which is called the VI polysaccharide vaccine, which is composed of the typhoid VI capsular polysaccharide from type V2 strain of the Salmonella typhi, and this is licensed for only above 2 years and more. It is present in the injectable form, and it is also present in the capsular form with the name of the capsule Vivotif. अभी आजकल मिल नहीं रहा है, मुश्किल से मिलता है, लेकिन injectable form जो है वो मौजूद है. So only one dose is required of VI polysaccharide vaccine, and this provides protection 7 days after the injection. Revaccination is booster dose is recommended every 3rd year. Okay, every 3 years, and it can be co-administered with many other vaccines. There is no problem of co-administration with hepatitis A or yellow fever or any other vaccine. No serious side effects, minimum local side effects. There is another vaccine which is available, and this is called the conjugate typhoid vaccine, TCV. Conjugate typhoid vaccine can be given to the children from 6 months of age. This is its advantage. Otherwise, if efficacy almost is the same of both. Our the typhoid control program is there, which is trying to control the typhoid, and it was being designed because of the outbreak of typhoid occurred in Hyderabad and Karachi in 2016, and more than 10,000 number of the cases of multiple drug resistance. This when we see XDR multiplied DR, multiple drug resistant of the typhoid were reported. इनके ऊपर कोई cephalosporin भी act नहीं कर रही थी. Ceftriaxone was given, but that the strain of Salmonella typhi was resistant with even ceftriaxone. The only drug came other than Tanzu or vancomycin or drugs like that, the fourth generation or fifth generation antibiotics. The drug which are effective was the azithromycin with a dose of 20 milligram per kg per day in a single dose. So that was being, so इस epidemic के बाद 2-3 साल पहले जो हुई थी, ये एक टाइफाइड कंट्रोल प्रोग्राम स्ट्रेटेजी जो है वो डिजाइन हुई इनसे, और उसके तहत जो है मेजॉरिटी ऑफ द पॉपुलेशन को जो है अंडर 15 इयर्स को इम्यूनाइज करने की जो है एफर्ट की गई, ताकि ये टाइफाइड होने से पहले रोका जाए, तो ये मल्टीपल ड्रग रेजिस्टेंस का प्रॉब्लम जो है वो होना. मल्टीपल ड्रग रेजिस्टेंस अकर्स ड्यू टू द इनएप्रोप्रिएट यूज ऑफ एंटीबायोटिक्स. Antibiotics, whenever it should be used in full dose and full course. ये हमेशा याद है. डर के एंटीबायोटिक यूज करना, कम डोज में यूज करना, जल्दी बंद करना, दैट कॉजेज द डेवलपमेंट ऑफ द रेजिस्टेंट इन ऑर्गेनिज्म. सो टाइफाइड कंजुगेट वैक्सीन is being it is a pre-qualified vaccine, pre-qualified in December 2017, protective against Salmonella typhi only, not the paratyphi. Licensed to use from 6 months to 45 years. A single dose is required. Presentation 1 dose और 5 dose के वायल आते हैं लिक्विड फॉर्म में. शेल्फ लाइफ इसकी जो है बहुत अच्छी है, 3 साल के करीब है. इसको 2 to 8 डिग्री सेंटीग्रेड के ऊपर जो है कोल्ड चेन में मेंटेन करना होता है. VVM इसके ऊपर होता है. VVM मीन्स वैक्सीन वायल मॉनिटर. ये जो आपको ये नजर आ रहा है, ये ग्रे कलर का जो है वो सर्कल है, और इसके अंदर ये व्हाइट कलर का स्क्वायर है. अगर ये वैक्सीन कहीं पर हाई टेम्परेचर से एक्सपोज हुई है, तो ये व्हाइट स्क्वायर जो है ये भी ग्रे हो जाएगा, और द कलर ऑफ द सर्कल एंड द स्क्वायर विल बी सेम, और इवन द स्क्वायर may be darker than the circle. This indicates that this vial has been exposed towards the higher temperature sometime in its transportation or storage. So if you see any vial in which this square is similar in color with the circle or even darker, don't use that. It means this is not. This is called vaccine vial monitor. Okay. Current open vial policy ये है कि एक बच्चा भी आए तो आप वायल ओपन करें और उसको लगाएं. ठीक है. Global Advisory Committee on Vaccine Safety was formed in December 18, and it indicates that इसके अंदर जो है वो साइड इफेक्ट्स जो हैं वो बहुत लेस हैं, and there is very safe. This is a very safe vaccine to be used and can be used in across the country. Now, applying the same all that knowledge, we have 3 or 4 slides more of malaria. If you apply the same strategy to the prevention of malaria, you can see there was a scientist, Paul Russell, in Brazil. He was a bacteriologist, but later than his work on malaria was enormous. So he was being called a malariologist. Malaria, अगर आप देखें तो malaria is the only disease which has killed more population as compared to all the wars in the history of human. इंसानी तारीख में जितनी जंगें हुई हैं, उन तमाम का डेथ एक तरफ रखें और सिर्फ मलेरिया से होने वाली डेथ्स को एक तरफ रखें, तो मलेरिया इज मच मोर लीथर. ज्यादा लोगों को मारा इसने. ये ऐसी है. मलेरिया है क्या? माल एरिया. इट वॉज बीइंग सपोज कि एक जो है वो दलदली इलाका है, जंगल है, जहाँ से लोग गुजरते थे, और जब भी वहां से वो गुजर के आते थे, शदीद सर्दी और कपकपी उनको चढ़ती थी और तेज बुखार चढ़ता था. तो माल एरिया, बुरी हवा, वो देवर सपोज के वहां पे जनाब कुछ बुरे असरात हैं वगैरह वगैरह, तो वहां से जो गुजरेगा उसे ये असर हो जाएगा. देन आगे जाकर जो है वो ये पता चला कि जनाब ऐसी कोई बात नहीं है, और ये एक मच्छर काटते हैं और उसकी वजह से ऑर्गेनिज्म जाता है और इस तरह का बुखार होता है. पॉल रसल ये कहता है कि मलेरिया, कंट्रोल ऑफ मलेरिया इज वेरी इजी, as easy as prescribing 2 tablets of chloroquine every week to every individual in the world. दुनिया का हर आदमी अगर 2 क्लोरोक्विन की गोली हर हफ्ते खाता रहे, तो उसको मॉस्किटो बाइट भी करता रहे, मलेरियल पैरासाइट आता भी रहे, उसको मलेरिया नहीं होगा. इट इज दैट इजी, बट इट इज दैट डिफिकल्ट. ये खुद भी इजी नहीं है. खैर, दुनिया के हर शख्स को हर हफ्ते 2 टैबलेट क्लोरोक्विन की देते रहना, लेकिन अगर हम ऐसा 2 साल तक करते रहें तो मलेरिया खत्म हो जाएगा। क्योंकि जैसे ही मॉस्किटो काटेगा, बाइट करेगा, स्पोरोजाइट्स एंटर होंगे, बट दैट स्पोरोजाइट्स विल बी किल्ड बाय क्लोरोक्विन। तो वहां पर जो ह्यूमन साइकिल है, जो एसेक्सुअल साइकिल है, वो नहीं होगा और गैमेटोसाइट्स नहीं बनेंगे। गैमेटोसाइट्स नहीं बनेंगे तो दूसरे मॉस्किटो जो बाइट कर रहे हैं उनको गैमेटोसाइट नहीं मिलेंगे। साल या 2 साल के अंदर मॉस्किटोज की एक जनरेशन आ जाएगी जिसके अंदर मलेरिया पैरासाइट है ही नहीं। उसके बाद अगर आप ये स्ट्रेटजी छोड़ भी दें तो मॉस्किटोज आर स्ट्राइल नाउ। सो ये डिफरेंट स्ट्रेटजीज होती है कंट्रोल करने की मलेरिया के अंदर। ओके, एक सूरत ये है, हमने क्या किया, हमने जो है रेजर्वायर खत्म कर दिया। तमाम ह्यूमन बींग्स में से गैमेटोसाइट खत्म हो गया, और गैमेटोसाइट जब मॉस्किटोज को नहीं मिला, इन तमाम ऑल द मॉस्किटोज नाउ दे डोंट हैव स्पोरोजाइट्स, सो स्पोरोज रिजर्वायर्स खत्म हो गए। देन सेकेंडली व्हाट वी कैन डू कि हम ट्रांसमिशन चैनल को हम जो है वेक्टर को खत्म कर दें, मॉस्किटोज को खत्म कर दें। थर्ड चैनल ये है कि किसी तरह कोई वैक्सीन आ जाए तो हम सबको इम्यूनाइज कर दें। सो दीज 3 अप्रोचेस दे मे बी टेकन ऑन। ओके, एक अप्रोच ये है कि हमारा ट्रीटमेंट इतना अच्छा हो कि हम मलेरिया को जैसे ही इन्फेक्टेड पर्सन आए तो हम इस तरह ट्रीट करें कि उसका सिम्टम भी खत्म हो और उसके ब्लड के अंदर जो गैमेटोसाइट्स हैं वो भी खत्म हो। इसीलिए क्लोरोक्विन और एमोडायाक्विन या बेजोक्विन की जगह जो नई ड्रग्स आई, artemether and lumefantrine, they are effective against gametophyte as well. This is the technical reason behind them. So active intervention and control or interrupt malaria transmission is there. Good management of the malarial cases, uncomplicated cases and severe and complicated cases. Then chemoprophylaxis, you came to know, giving chloroquine 2 tablets weekly or giving Fansidar tablet 3 tablets weekly. And these chemoprophylaxis is recommended for the travelers कि यूरोप अमेरिका जहाँ पर जो है वो नहीं है मलेरिया, वहाँ से कोई ट्रैवल कर रहा है, साउथ अफ्रीका, पाकिस्तान, इंडिया, तो यहाँ पर है तो वो टैबलेट्स लेना शुरू कर दे जाने से 1 हफ्ता पहले। शुड बी कॉम्प्लीमेंटेड बाय पर्सनल प्रोटेक्शन एंड अदर वेक्टर कंट्रोल मेथड्स। रिपेलेंट यूज कर लें, बेड नेट्स लें, क्लोथ्स जो है वो फुल आस्तीन के हों और लॉन्ग बूट्स पहन लें अगर फॉरेस्ट या फार्म्स में जा रहे हैं। तो ये पर्सनल प्रोटेक्टिव मेजर्स हैं। देन वेक्टर कंट्रोल स्ट्रेटजीज है, वेक्टर्स के अंदर एंटी एडल्ट मेजर्स हैं, रेजिडुअल स्प्रेइंग, डीडीटी, मैलाथियोन, रिडाल्ड्रेंस हैं। स्पेस एप्लीकेशन इन द फॉर्म ऑफ मिस्ट जो है वो स्प्रे किए जा सकते हैं फॉर मॉस्किटो टू किल द मॉस्किटो। डिक्रीजिंग द ब्रीडिंग प्लेसेस ऑफ मॉस्किटो, इंडिविजुअल प्रोटेक्शंस लाइक द यूज ऑफ रिपेलेंट्स, प्रोटेक्टिव क्लोथिंग्स, बेड नेट्स, कॉइल्स, स्क्रीनिंग ऑफ हाउसेस, एक्सेट्रा। Anti-larval measures, larvicides at the breeding places, at the stagnant water, at the pools of water. This causes the source reduction. And then malaria vaccine, which is still not present there. Rollback malaria global strategic plan started in 2005, planned till 2015. It is still continuous, going on. Target to reduce the morbidity of the cases of malaria, mortality of the malaria up to 75%. And this program seeks to strengthen health system to ensure better delivery of the healthcare at district and community level. Ensure the proper and expanded use of insecticides, treated mosquito nets. Ensure adequate access to basic healthcare and training of health workers. Encourage development of more effective and new anti-malarial drugs and vaccines. Okay, so chloroquine resistant now had been reported in many countries, and that is why the new many countries and many societies, that is why the new drugs that I said the artemether and lumefantrine, the most advanced, more advanced as compared to chloroquine and amidaquine, are present now since last many years, and their दो एडवांटेजेस हैं इसके फेंसिडार, आर्टेमीथर, ल्यूमेफेंट्रिन के। नंबर 1 ये कि रेजिस्टेंस कम है इसमें क्लोरोक्विन की बनिस्बत। नंबर 2 ये कि ये जो है क्लोरोक्विन जो है वो गैमेटोसाइट्स के अगेंस्ट इतनी इफेक्टिव नहीं है, but these drugs are new drugs which are effective against gametocyte as well. So they not only treat the patient, but as well they prevent the further propagation, spread of the disease. Okay, I recommend 2 major books. There are 3 major books which are available to study the community medicine. The first book that I recommend is the most good book is the Ilyas et al. Okay, then second is the Park, and then there is Dr. Zulfaqar book of the community medicine. So if you are reading any one of these, especially you see most of the time जो हमारे वाइवास और BCQs बनते हैं वो इलियास एट al से ज़्यादा बनते हैं, लेकिन आप इन 3 बुक्स में से अगर देखेंगे तो आपका टॉपिक तकरीबन तमाम का तमाम जो है वो कवर हो जाएगा। नोटिफिकेशन मैंने बताया था कि ये हेल्थ मैनेजमेंट इंफॉर्मेशन सिस्टम का एक जो है वो है स्टेप है, और नोटिफिकेशन जो है वो ये है कि किसी जगह पर कोई बीमारी मैंने देखी, मैं अपने क्लिनिक पे बैठा हूँ, उस बीमारी को मैंने रिपोर्ट किया एक फॉर्म भर के कि पिछले महीने में मैंने इतने मिजल्स के केसेस देखे, दैट मच ऑफ दी टाइफाइड केसेस, दैट मेनी ऑफ दी टेटनस केसेस एक्सेट्रा, और ये रिपोर्ट मैंने हायर हेल्थ अथॉरिटीज को भेजी। दिस इज व्हाट द हेल्थ मैनेजमेंट इंफॉर्मेशन सिस्टम, दिस इज कॉल्ड नोटिफिकेशन। इंसिडेंस एंड प्रिवेलेंस का फार्मूला मैंने बताया था कि इंसिडेंस इज द न्यू नंबर ऑफ केसेस, प्रिवेलेंस इज द टोटल नंबर ऑफ केसेस। इंसिडेंस फार्मूला जो है न्यूमरेटर इज द टोटल नंबर ऑफ न्यू केसेस ड्यूरिंग अ टाइम ड्यूरेशन, डिनोमिनेटर हमारा है टोटल पॉपुलेशन मल्टीप्लाइड बाय एनी कांस्टेंट। सो न्यूमरेटर नंबर ऑफ न्यू केसेस, डिनोमिनेटर टोटल पॉपुलेशन एट रिस्क एंड कांस्टेंट, दिस इज व्हाट द इंसिडेंस इज। तब्दीली क्या होती है? प्रिवेलेंस में टोटल नंबर ऑफ केसेस, न्यू केसेस नहीं है इसमें, न्यू ओल्ड दोनों आ गए, ठीक है, न्यूमरेटर बदल जाता है, डिनोमिनेटर वही रहता है, टोटल पॉपुलेशन कांस्टेंट वैसे ही रहता है। सो दिस इज द डिफरेंस। अच्छा जनाब, ये एक someone got typhoid fever in childhood and got cured but did not got test for being a carrier, so what should he should do? Nothing. एक अगर वो कैरियर है तो उसके स्टूल में जो है वो ऑर्गेनिज्म आ रहा होगा, ठीक है। मेन सोर्स आप समझ लें, मेन रिजर्वायर गॉल ब्लैडर है, गॉल ब्लैडर से वो इंटेस्टाइन में आएगा, स्टूल में आ रहा होगा। अगर वो एक स्टूल कल्चर करा ले और वो स्टूल कल्चर जो है वो नेगेटिव है तो देयर शुड बी एक आप डायग्नोसिस पे आ जाएंगे कि कैरियर है या नहीं है, ठीक है। देन व्हाट इज टाइफाइड कंजुगेट वैक्सीन? टाइफाइड कंजुगेट वैक्सीन इज अवेलेबल, दिस इज कंजुगेटेड। ये जरा सा बड़ा टॉपिक है कि कंजुगेट वैक्सीन क्या होते हैं, किस तरीके से बनाए जाते हैं, ऑर्गेनिज्म के साथ किस तरह एक मॉलिक्यूल जो है उसको मिला दिया जाता है, दैट इज व्हाई दिस इज कॉल्ड कंजुगेट। दिस इज वायरोलॉजी एंड बैक्टीरियोलॉजी है, किसी वक्त इसको देखेंगे। दिस इज अ टाइप ऑफ वैक्सीन, 2 टाइप ऑफ वैक्सीन अवेलेबल है, एक VI पॉलीसैकेराइड वैक्सीन, एक कंजुगेट वैक्सीन है। सो इफ यू विल जस्ट सी द इम्यूनिटी एंड इम्यूनाइजेशन, वो उस चैप्टर में पार्क में भी और इसमें भी इन इलियास एट al दोनों में ये टॉपिक मौजूद है कि टाइप्स ऑफ वैक्सीन जो है वो क्या होती हैं, ठीक है। एक मिनट में जरा सा Will we study smallpox even though it has been eradicated? Smallpox को आपको स्टडी करना होता है, ठीक है। कोई भी डिजीज जो दुनिया में आई अब बेशक नहीं है, उसको आप किसी ना किसी एंगल से यू आर बीइंग स्टडिंग इट। स्मॉलपॉक्स के अंदर जो स्टडी करने का एक बहुत खूबसूरत जो उसका वो है वो ये है कि हाउ डिड वी इरेडिकेटेड स्मॉलपॉक्स, और क्या वो स्ट्रेटजी जो है जो हमने अप्लाई की वो थी क्या, उसमें कौन से पॉजिटिव पॉइंट्स थे, उसको हम रेप्लिकेट दूसरी डिजीज पे, कौन सी डिजीज पे कर सकते हैं, या उसके बेटर पॉइंट्स हम कहाँ पर रेप्लिकेट कर सकते हैं, और उसके वीकर पॉइंट्स जो हैं किस तरह हम उन्हें जो है वो अवॉइड कर सकते हैं, ठीक है। सो स्टडी तो हमें करना ही होता है, नॉट इफ द एग्जामिनेशन पॉइंट ऑफ व्यू, विद द नॉलेज पॉइंट ऑफ व्यू। 2 doses. I didn't say 2 doses of chloroquine per week. I said 2 tablets of chloroquine per week. Okay. It would protect from malaria, but there is a question of the resistance of the malaria is there. So this occurs. I have answered the resistance question. If we can use 3 tablets of Fansidar weekly as alternative of this chloroquine. Concept of herd immunity is for contagious diseases only. ठीक है, concept of herd diseases is for any disease which produces antibody in the body. Okay, if any disease as a result of immunization or as a result of natural infection is producing antibody in the body, then herd immunity concept will come there. Okay, because if I am having antibody in my blood, okay, organism comes to me, it will not cause disease in me. So the person sitting nearby me, it will get protected spontaneously, automatically, because one person from the left infected me, but I am not getting infected, so I will not transport that infection to other population. This is what the herd immunity. लेकिन वो diseases जहाँ पर antibodies नहीं बनते, वहाँ पर herd immunity का concept नहीं है. Diabetes में नहीं हो सकता, ठीक है ना, hypertension में नहीं हो सकता, वो उनके factors कुछ और हैं. So every disease has different factors. Last two questions मैं ले रहा हूँ, ठीक है. Herd immunity मैंने एड्रेस किया. Sir, what the main reason that Pakistan polio is still prevalent in Pakistan? Multiple reasons हैं. ये बहुत important question है. और मैं आपको बताऊं कि आमतौर पे जब community medicine के interviews हो रहे होते हैं ना, असिस्टेंट प्रोफेसर्स के, लेक्चरर्स के, वहाँ पर ये सवाल किया जाता है कि जनाब पाकिस्तान में ऑलमोस्ट 90 अबव जो है वो पोलियो कैंपेन्स हो चुकी हैं और फिर भी जो है वो पोलियो स्टिल है. मल्टीपल रीजंस हैं. रीजंस जो हैं वो जनाब कोल्ड चेन मेंटेनेंस, आप जो पोलियो के ड्रॉप्स पिला रहे हैं उनकी कोल्ड चेन पीछे मेंटेन नहीं हुई थी, तो वो इतने इफेक्टिव ही नहीं थे. चलें, अब ये प्रॉब्लम सॉल्व हो गया वैक्सीन वायल मॉनिटर से कि हमें पता चल जाता है, ठीक है. देन जो है आपकी रूटीन इम्यूनाइजेशन जो है वो इतनी परसेंटेज कवरेज उसकी हाई नहीं है. आप जो है ज़्यादातर डिपेंड कर रहे हैं पोलियो कैंपेन्स पे, जबकि उसकी बेस जो है रूटीन इम्यूनाइजेशन होती है. रूटीन इम्यूनाइजेशन में अगर बच्चे को 3 डोजेस मिले हुए हैं पोलियो के, तो ये कैंपेन उसके ऊपर आकर जो है वो काम ज़्यादा अच्छा करती हैं. जिन मुल्कों की रूटीन इम्यूनाइजेशन अच्छी है, कवरेज अच्छी है, वो आपकी पोलियो जल्दी जो है वो इरेडिकेट हो गया, ठीक है. देन पॉलिटिकल रीजंस भी हैं, दहशतगर्दी भी थी, लोगों को मारा गया, तो वो चीज़ें जो है वो सॉरी. एक चीज़ याद रखें कि पोलियो का एक केसेस तकरीबन 400 केसेस को जो है इन्वॉल्व करता है. ओके, थैंक यू वेरी मच. एंड
यस सर, अस्सलाम वालेकुम. क्या सेंड कर दूं?
इन नेक्स्ट जी प्लीज. थैंक यू वेरी मच, बहुत बहुत शुक्रिया.
ओके सर, अल्लाह हाफिज़.
अल्लाह हाफिज़.